The clinical case: a 72-year-old man with Parkinson's disease develops visual hallucinations after long-term levodopa therapy, which antipsychotic is preferred without significantly worsening his motor symptoms. The options are A. Haloperidol, B. Risperidone, C. Quetiapine, D. Flufenazine. Guess the correct answer. The correct answer is quetiapine. Let's understand the problem first. Parkinson's disease is already characterized by reduced dopaminergic activity in the nigrostriatal pathway, producing motor symptoms such as bradykinesia, rigidity and tremor. Now, this patient has also developed psychosis. So, we need an antipsychotic, but potent D2 receptor blockade in the nigrostriatal pathway can further reduce dopaminergic activity and produce extrapyramidal symptoms, worsening his Parkinsonism. So how do we choose? The key is the drug's propensity for D2 receptor blockade and extrapyramidal symptoms. We want an antipsychotic that can control psychosis while producing minimal interference with nigrostriatal dopamine transmission. So among these options, choose the drug with lowest tendency to produce clinically significant D2 blockade and extrapyramidal symptoms. Haloperidol? No, it is high potency typical antipsychotic with strong D2 blockade and high risk of extrapyramidal symptoms. So it can markedly worsen Parkinsonism. Flufenazine? Again, no. It is another high potency typical antipsychotic with potent D2 blockade and significant extrapyramidal symptoms risk. Risperidone? Although atypical, it still produces substantial D2 receptor blockade, especially as the dose increases, and can worsen Parkinsonian motor symptoms. Quetiapine, yes, it has relatively low and transient D2 receptor occupancy and therefore has a much lower propensity to cause extrapyramidal symptoms. So the correct answer is quetiapine.